Hi, my name is Natalie Carter. I am currently a consultant midwife working in London, and I've been a midwife for nearly 12 years, and I was a nurse prior to doing my midwifery training. I've always wanted to be a midwife. My mum said I talked about being a midwife and bumps and babies from about the age of 6, 7. So I think I'm really fortunate I've had that calling to be a midwife, and I feel very, very lucky to work within a job that I really, really love. I have been working for about 12 years, predominantly within community services, although I do work a bit more in a senior team now. So I've worked across the midwifery birth journey. I've worked with women in the antenatal period. I've often case-loaded, so I've looked after them from the beginning all the way through, been with them at their births, been with them through the postnatal journey, and seen them through discharge when we say goodbye. And I was actually Siobhan's midwife for her second and third boys, Arlo and Albie, which has been a real privilege, and even more so to be able to work with her now on her fantastic company and providing some of this information for you guys. So in the next series of videos, I'm going to be talking a little bit more about what we do as midwives for you in the postnatal period after you've had your baby. I want to talk a little bit about something called the fourth trimester. I want to talk a bit about what happens immediately in the hours after birth, whether you're in the hospital or a birth centre or at home. I want to talk about what the health professionals are doing and who we are, because it's not just midwives that will be doing some of your care. And I want to talk through that recovery and well-being of both a mother and a baby, and all of that encompasses. A bit of a section on taking care of a newborn baby, and we're predominantly going to focus on the sort of first 4 weeks of your baby's life, although I'm going to talk a little bit about the first 3 months as well. And then a little bit about my own personal experience, because I actually have just had my first baby, a daughter called Thea, and she is currently 4 months old and sleeping upstairs as we do this now. Having just had my own first baby and actually living a lot of what I've been talking about over the last few years, I hope that by providing some of the information I'm going to in the next series of videos, I can reassure you and give you really good expectations of what that initial postnatal period is really like, some of the things I've learned myself doing it, some of the tips, and empower you to be able to make some of your own choices in that newborn period about how you would like to become parents and provide care to your newborn baby. And I hope that this reassuring pack of all of the information that's been provided to you by Siobhan is going to help it be a very positive, joyful period amongst some of the challenges that it does bring as well. So I just want to take a moment to talk about something that you might have heard called the fourth trimester, which is not necessarily anything that's set down in textbooks or part of the sort of biology like the first and second and third trimester you'll have heard talked about when you were pregnant. But there is a theory out there, and it's a theory only, there's no evidence behind this, but a way to try and explain the behaviour of a baby in the first 3 months of their life, and it's been nicknamed the fourth trimester. And it starts to talk about why babies might find that period of time unsettling, why you hear people talk about babies that cry a lot, the witching hour, where babies tend to cry of an evening, quite typically, predictably, what it is that's going on. And some people have described what conditions those babies are exposed to in the womb in terms of warmth, dark, a lot of noise. If you think about your bowel sounds, your digestion sounds, your heartbeat, there's an awful lot of noise going on inside. So babies are exposed to a lot of noise for 9 months before they're born. So this theory about the fourth trimester is that once that baby is born, and perhaps we have expectations that we're going to be able to lie them down on their back in a cot away from us and they're going to go to sleep, are maybe a little bit unrealistic because of the transition they're making from the experience they've been having inside of us. And so replicating some of that experience in terms of contact, closeness, warmth, dark, and noise is something that can often make that fourth trimester period, that first 3 months, more supportive, a transition for that baby who's getting to grips with life outside. If you imagine that you yourself have been in an environment that's been dark and warm and you felt very close and comfortable, it's really noisy, and you're asked to transition into something that's bright and you've got all this space around you and it's maybe very, very quiet, you can imagine that actually might be really unnerving for you, and we might need to support that transition. So in that first 3 months of life, your baby is transitioning and asking you to help them feel safe. And in the ways in which they will ask that of you, and they'll ask by crying, because that's the only communication tool they have, is to say, please hold me, please help me feel warm. Perhaps they like being exposed to noise, the quiet is a bit unnerving for them. They will want to be fed, to feel close, to feel loved. And I think babies actually quite like to begin to learn who their family network is. So rather than lots of multiple people holding them, you might find they like to be held by a certain few, and that's them saying, well, who are my main care providers? Who is it that I'm going to be safe with, and who's taking care of me? Let me look at you, let me imprint your face, let me recognise you as being the person that I'm safe with. When we talk about giving babies bottles, so if you've chosen to bottle feed your baby or give your baby express milk via a bottle, we still ask that only a few people, if you can, provide that nutrition for the baby and do those feeds, because feeding is one of the ways in which that baby is bonding with you and learning what that face looks like and who they are safe with. So the ways in which we help those babies feel safe and help transition from being inside that womb environment is by holding them, is by having skin to skin, is by feeding them regularly, helping them feel safe, calm. Perhaps they enjoy being in a noisy environment. Siblings often cope really well because there's older children making lots of noise around them. So the first baby, do be noisy. Don't worry about the Hoover, that TV being on, because actually that baby's been exposed to quite high levels of noise when they've grown inside of you. So continue that, and perhaps they'll settle really well with noise, or perhaps they won't. And it's about finding out what works for your baby. But these are the reasons why your baby wants to be held and isn't going down in their Moses basket or their bed nest as well as you might have expected them to. And it's the fourth trimester that has been nicknamed this period of time where you might be finding you are holding them a lot, and it is just about recreating that experience that they had in the womb and letting them slowly uncurl, slowly get used to the light, the different environment, the space around them, rather than expecting them to do it on day one when they've just been born. Please don't worry about feeling that you're developing bad habits or spoiling your baby by holding them as much as you might in that fourth trimester, first few month period. These babies really are just asking to be made to feel safe. They're not developing learning habits at this developmental stage. They're not able to with their neurological development. And actually, a lot of recent studies have shown that the more we hold our babies, the more love we show, the more warmth and closeness that we give them, the more independent they become later on, and the more well-rounded and developed adults they are. So there's 3 places of birth that you may have given birth in. You might have had your baby at home, you might have had your baby in a birth centre or on a consultant-led labour ward. And I just want to talk a bit about the immediate postnatal period and going home from there, or if you've been at home, of course, when the midwives might leave you. So after the whole birth process is complete, some women will opt to go home shortly afterwards, or your midwives might leave you if you've given birth at home, or you might go on to what's called a postnatal ward, where you have a bit of a longer stay, anywhere between 12 hours to a couple of days. And particularly if you've had a cesarean or an epidural for your birth process, then you'll definitely have that longer stay on the postnatal ward just while you recover. If you've given birth at home, typically, and this can vary a little bit hospital to hospital, so this is not exact guidelines, but typically midwives will be with you for about 3 hours after the whole birth process is completed. And what I mean by that is that placenta is born, if the woman needed any stitches, they've been done, she's perhaps gotten up and had a shower, and then we might be sitting doing some paperwork. So the midwives are probably there after that for then about 3 hours. If you're in a birth centre, again, a woman might choose to go home after that 3 hours, anywhere between 3 to 6 hours straight home from a birth centre, or for various reasons she would like to stay, or there's a concern that we have, or she wants some feeding support with the baby, she'd be transferred to a postnatal ward and stay a bit longer there. The things that we're doing for you in that immediate postnatal period, in terms of the woman, we are obviously supporting your immediate needs. That might be some pain relief. We're having a check on what your bleeding is like. We're making sure that you're comfortable, that you've had something to eat and drink, you're feeling okay. Sometimes you've got questions about the birth that just happened over the last day or 2 days, and we might be answering some of those questions. We're going to be supporting your feeding of your baby, however you've chosen to do that. And one thing I did want to say, you need to check with your hospital. If you've chosen to bottle feed your baby, a lot of hospitals now ask you to bring your formula in with you. So you might need to just check if you need to provide that if you're going to bottle feed. If you've chosen not to bottle feed, but for any reason your baby is unwell when you're in hospital and they need to have some formula via bottle, then the hospital will provide that for you. So you don't need to worry that you don't have any if there is an occasion when the baby does need it, because the hospital would provide it under that circumstance. It's just that if you've chosen to feed with formula, they just ask you to bring it in with you. During this time, as well as making sure the woman is comfortable, we are also checking that the baby is well, has had a first feed, is nice and warm and pink, done a check over, making sure that we're happy nothing's wrong or we're worried about anything, answering any questions the parents have got about how to look after their baby, that first nappy change, all those expectations and what to look out for. So when you are in that environment with us, whether we're still at home with you or you're still in the birth centre or hospital, we're obviously there on a kind of permanent basis for you to ask any questions that come up as they come. While you're in hospital, there are a few checks that we do for every mother and baby, or particularly your baby actually. The first one you might hear referred to is the NIPE, which is a newborn examination, newborn infant physical examination. And it basically takes a history from the parents about whether there's anything in the family that we need to know of, any baby that's been born with a heart condition in the past, just so that we maybe do an extra check on your baby to make sure they've not inherited that. So a family history, anything that you've got a concern about, anything that might have cropped up in the pregnancy, take a history, and then we do a physical check of the baby's reflexes, their overall physical appearance of their body. We have a look in their eyes, we listen to their heart, we're checking all their reflexes, their hip joints, making sure that there's no problems. For example, some babies that might have been presenting bottom down, which we call breech, for a lot of the pregnancy, even if they turned to head down at the end and had a normal birth, sometimes they might have a little bit of clicking happening in their hips because of that position they've been, where their legs have been extended up because they've been sat down. So sometimes at about 6 weeks old, we might refer you for a scan to check that those hips are okay, which more than often they're absolutely fine, and it's just a precaution to check. So this examination just goes through lots of things. There are several people that are qualified to do that. So midwives are qualified, and also the paediatricians or the neonatal doctors. Either or can provide that check for your baby. So if you've given birth at home or in the hospital, but you go home quite quickly, so you have a 3 to 6 hour discharge home, it might be that you've not had an opportunity to have your baby have that check yet. That check can be completed within 72 hours, so we have time. So sometimes the midwife might come out to you at home to provide that check once you've been discharged, or you might be given a clinic appointment to return the next day or the day after. And in some areas, GPs are still coming out to do those checks. So sometimes a GP might pop in to do that check, or you go to your GP surgery as well. The other check that's probably happening for your baby while on the ward before discharge is the hearing. So all babies get a hearing screen. It very, very often comes back inconclusive. So I would want to reassure you that not to worry if you're told that the baby failed their hearing test, particularly if it's just in the one side. Babies have a lot of fluid in their ears from the birth process, regardless of how they were born. But often also if they were born into water, into one of the water pools, that's even more water. So if they've got a lot of water in their ear canal still, and if we do that hearing check quite soon after birth, they will often not pass that first check. Please don't worry, it's really common for it not to pass, in which case you'll be sent an outpatient clinic appointment for a couple of weeks' time where they'll check it again. And the same, if your baby is born at home, so you're not able to have that check because you're home, then they'll send an outpatient clinic appointment for a couple of weeks' time, so you won't miss that screening out. So once we've given you all of your immediate care, whether you've been at home in the birth centre or in the hospital, and you're ready to go home, and sometimes you may have stayed a bit longer if your baby's needed antibiotics or has had a couple of days stay in the special care baby unit. So sometimes you have been in a little while, but once you're ready to go home, and if that's at 2 hours after birth, that's also absolutely fine. But what's important is that you feel ready. So on discharge, a midwife is going to come and give you some paperwork. We always love our paperwork and our leaflets. I would encourage you to go home and when you have a moment to go through and read some of those leaflets, because actually there can be some very useful information in there, and you'll forget what you've been told because you're tired and you've been through a lot and it's overwhelming and you're taking your new baby home. You often forget what the midwife is telling you when you are discharged, but she will give you a lot of information about what to look out for signs of wellness in both the mother and the baby, and what's going to happen next in terms of who's coming to see you and appointments. So do go home and maybe check in with your leaflets again, because it will re-go over all of that information and just help keep it in your mind. It is actually something really good for the birth support partner or family member to do, is to go home and reread those leaflets to reconfirm that information, because you can help keep an eye on the woman and her baby where she might be too tired to do some of that because you've reread the information and it's quite fresh in your mind. So the midwife will give you this information, which I'll go over in a minute, and the paperwork of your discharge, of which you'll be given some copies to keep, one for a GP, one for a health visitor that's going to come and see you, and that's just like a summary of the birth experience and what's happened to both the mother and the baby. And in some hospitals, you'll be given your red book, and you'll actually go home with that red book, which is your baby's health record from the age of 0 to the age of 5, and I'll talk a little bit more about that in a minute. It's really important that you have a car seat to take your baby home in so that they have a safe journey home. You might be going home in a taxi. I hope you're not walking home, even if you live really, really locally, because the woman really shouldn't be walking too far having just given birth. So even if you live really local, I do encourage you to get a taxi or a lift so that the woman is not having to mobilise too much too soon. But again, everybody needs to make an individual decision about that depending on how you're feeling. So just make sure you have a car seat to safely get your baby home in when you leave the hospital. Regardless of how you might have given birth to your baby, it's highly likely that you're going to be feeling tired. Most babies come at night time, so you probably have lost at least one night of sleep. So when it comes to visitors, it's obviously really lovely to have your loved ones come and meet the baby for the first time. But it's really important that you manage that quite carefully, because it can be quite overwhelming when you're feeling like you might just need a moment to yourself, to your immediate family network, without too many people coming and disturbing you. So be careful with who comes to the hospital to see you or how long they stay, and the same with if you've given at birth, who immediately comes. Think about who you want to come, how you manage the time they stay. I would always suggest that nobody comes to visit unless they bring you food as well. It's so helpful for people to bring meals, so they're allowed to visit as long as they come and bring dinner with them too. In terms of the hospitals, visiting will have specific guidelines attached to it on the individual hospital, but generally only about 2 people plus a woman's partner or female support partner will be allowed at any one time, so not an entire group of people because it's just too much on the wards. So 2 people at a time, but your partner or your existing children or your support partner will be able to be there sort of 24 hours while you're in labour, and then on the wards between about 8 and 8. But other visitors are often kept to the afternoon at around about 3 to 8 p.m. But you do need to check with your individual hospital what their visiting policy is before people come, so that nobody gets upset at the front door if they arrive to see you and actually the receptionist says, "I'm sorry, but I can't let you in." So please do check those policies before anybody comes to visit you, and just have a think about whether you want anybody to come at that moment in time, or whether you just want to delay things by a day or 2, or wait until you're home and ready. There are a few things that you can get before you have your baby to have at home ready for when you come home. For example, paracetamol and ibuprofen if you're not allergic to any of those and you don't have asthma and you can take ibuprofen. If you're okay to take those tablets, they're very good pain relief options, and the hospital is unlikely to send you home with those general painkillers. So if you have them in at home, buy them from a chemist, pharmacy, supermarket beforehand, that's really good, because as you get home you've already got that supply waiting for you to keep on top of any pain that you might be feeling. It's really important that you've got a lot of food in the house. So some women do lots of cooking prior to their baby coming when they've gone on maternity leave. Stock up your freezer with ready-made meals so that you have got ease of heating something without having to do the whole cooking because of the tiredness that you'll all be experiencing. But the importance of nourishing yourself with really good food in that postnatal period is really important. So just think about having that food in the house prior to, so nobody's got to go out and buy loads of things and do lots of cooking. That can be really helpful. However you may have chosen to feed your baby, you'll be doing nighttime feeds. So one of the other things that can be really helpful to have at home ready for when you're back after giving birth is a lot of snack type food. So in the middle of the night, it can be hard to be woken repetitively just when you've gotten into a really good sleep to then feed your baby again and do nappy changes and repeat that cycle. So having something that you love as a snack in the middle of the night to then have to keep up your energy, but also as a bit of a treat and a luxury, is a really nice thing to do. And it can be whatever it is for you that brings that little bit of joy, whether it be chocolate or fruit or cereal bars or whatever it is that you really love to snack on. I would get a really big supply of that in for your nighttime. So already, having been pregnant and given birth, you've come into contact with a number of different health professionals, and I just wanted to talk about those people that are going to be part of your postnatal care as well. So after the birth, whether you're at home or the birth centre or the hospital, you obviously have come into contact with Midwife. She's still providing care to you afterwards. You may have had care from an obstetrician, one of the doctors. You may have had care from what we call a maternity support worker, who's supporting us through all of the stages of your pregnancy and birth and afterwards as well. You may have had a paediatrician or a neonatal doctor provide care to your baby to some degree. And a lot of our admin team will often support us by doing discharge paperwork and sometimes doing talks about that paperwork journey going home. So there's a number of people you've already come into contact to. When you go home, your midwife is going to continue to see you, and also maternity support workers do visits at home as well, so that's somebody that you may also see at home. You may know those people already because they may have been part of your antenatal team, or they may be new to you. Every hospital has a slightly different way of working their community service. You will also be asked at some point to make a GP appointment, so your GP is going to become a part of, or remain a part of your care, because hopefully you will have seen them for some of your antenatal appointments as well. And you're also potentially going to have an appointment with an obstetrician after a few weeks, because there might have been a complication in your pregnancy like diabetes or obstetric cholestasis, which means that you've got a follow-up appointment to come back and talk about whether you need another test to check that's okay, or what about next pregnancy and birth, or how you manage that in your life moving forward. Some of you may have had an appointment with your health visitor when you're about 28 weeks. Some see you in the antenatal period and some don't, so that's a bit variable across the country. But the health visitor is the person who's going to take over once the midwife team discharge you, in terms of supporting the checks for your child's development up until the age of 5, when they will actually go to school and the school takes over. So from birth to 5 years old, the health visitor team are a support network for you in terms of advice for sleeping, feeding, weaning, vaccines, and many other things. And they will make contact with you if they haven't already during your pregnancy to come and do a home visit when you're about 10 days, 2 weeks after the birth, and they'll explain a bit more about their role. They'll make sure you've got the red book if you weren't given it when you left the hospital, and explain about vaccine appointments and what you need to do next, and where they're based with contact numbers so that you can get a hold of them if you have questions in between the times when you'll see them for developmental checks. When you go home, or the midwife leaves you after you've given birth at home, This can be an anxious time for some, particularly with your first baby, feeling the responsibility of taking care of them, keeping them alive, making sure that they're all well. And we understand that you may have many questions that crop up when we might not be there because you're now home. So you would get lots of contact numbers for you to ring the health professionals who are providing your care to make sure that you've got access to that help when you need it. So you'll have your local information. So that will probably include contact for your community midwives, but that means that that won't be overnight because they work during the day. But during the day, you should be able to contact your community midwives. Sometimes they can do extra visits if things have gone, if you've had a bad night with your feeding and you're worried, they might often be able to do an extra visit to see what's happening. But in the middle of the night, and often these things are in the middle of the night when we're worried, you should have a 24-hour number, which is commonly the labour ward at the hospital where you gave birth or the birth centre, because of course we're there 24 hours and there's always somebody on the end of the phone for you to ask or anything that you're worried about. So those contact numbers will be given to you. But you've also got the National 111 number, so you can always get advice by ringing them. And of course you've got A&E services for when you're really worried and you feel like you need somebody to be seen straight away, whether it's you or your baby. You can always go to A&E or to your maternity triage if you're that worried and you want to be seen. When women have had a baby, we will still see you for 28 days after birth in the maternity unit. And after that first 28 days, then it tends to go to the A&E GP services. But for that first 28 days, we will always see you back in the maternity unit. But if you ring us, even if your baby's 3 months old, we're always going to be on the end of the phone and advise you who you need to see and whether everything's okay. The midwives and the maternity support workers that are coming to see you at home or in the clinics after birth are a huge support network for touching base with you about your emotional well-being. Now, there's a very normal stretch of up and down with our hormones, adrenaline, and our emotions after birth. We can feel very overwhelmed and tearful, and this be a very normal process. There may be some women who are on enhanced care plans already because perhaps they've got a history of some mental health concerns, and we're already building an additional layer of support for them because we know this is a vulnerable time. So the midwives that are coming to see you will be touching base with you about how you're feeling, how your emotions are. We don't want you to be too worried if you answer the door to us and you're already in tears, because we know that can be very normal around the time milk is coming in. And if you do have a few more questions about the in-depth stuff about that, then it would be really good for you to watch the maternal mental health section of this digital pack as well. Please feel able to talk freely to whoever comes to see you at home about how you're feeling emotionally. We don't expect you to be dressed and ready for our visit. We're not expecting you to, provide us with cups of tea and host us. We are here to support you and are expecting pajamas and perhaps a difficult night. Perhaps the woman is tearful, or maybe even her partner's feeling tearful that morning because you're tired, the feeding is a bit challenging, or you've not slept for a few nights because of the birth happening. There are so many things that could be affecting your mood at the moment, and it could swing day to day, in the day itself, high to low. Please feel free to talk to us openly. We're not there to judge you. We're not there to worry about your capacity as parents and whether your baby is safe. Yes, we're going to support all of those things and definitely want to support parenting, but we want you to be honest and free. Then we know how much or how little you need from us in terms of making you as well as possible, keeping you well at home and giving that postnatal period as much positive experience impact as possible by talking to you about what you really need. Every hospital is slightly different with their community services, but there probably is a mix for the postnatal support of both the midwife coming to see you at home, but also the option to go to postnatal clinics where you might be given a time and a clinic appointment. When the midwives are coming to see you at home, or the maternity support workers, you're very rarely given a time. We usually say to you, we'll come during the day sometime between 8 and 5. It's very difficult for us to give specific times because we never know until the morning who we're going to be seeing, what geography you're in, and how our day might go, and also how long we might be at visits. Because obviously a woman who's having a difficult feeding experience might need us longer than somebody who's absolutely fine. So some women prefer postnatal clinics because you do get that time for the appointment. So it's worth asking your community team what options are available to you in that postnatal period. So this section is about your own physical and emotional recovery from giving birth. And I'm going to talk a little bit about what the midwives will be doing when they're coming to see you at home and perhaps on the ward before going home, and the questions they're going to be asking. And the way I like to approach this, partly so that I never ever forget anything, is to look at it as a top to toe approach of how you are. So that's how I'm going to talk you through it now. So if we go from the top, then you might find that midwives start asking you about headaches and vision and whether you're experiencing any problems there. In a very, very small number of cases, if you've ever heard of preeclampsia, which is when a woman can get a high blood pressure, very small numbers of women can actually experience this after giving birth, usually within the first 24 to 48 hours after giving birth. So if you get any sudden, strong headaches, particularly if you have visual disturbances, that's a really important thing to let us know about, because we would just want to check your blood pressure was okay, particularly if you'd had any blood pressure problems in the pregnancy. So we'll be asking you about headaches. Most commonly, women might get some headaches after birth, but it's actually associated with being tired, perhaps having gotten dehydrated. And the way you can help yourself if you are experiencing headaches is to see if you can go and get a nap, to get another half an hour sleep, to make sure you are eating and drinking plenty so that it's not, dehydration is not the cause of that headache. So moving down from the head, regardless of how you've chosen to feed your baby, we need to just check that your breasts are okay. So we'll be asking you whether they're feeling soft or full, firm, any pain. Do they get red on any of the segments? Are there any lumps? Do they feel hard or hot? What are the nipples like if you're breastfeeding? How are the condition of the nipples when the baby's latching and feeding? Do we have any trauma or soreness that we need to take a look at? Some women might have a physiology where they've got inverted nipples and we need to be helping you a little bit with latching with baby. Some women might find that they're actually quite sore and we're looking at cream and things that we can do to help make that, help that improve if you're breastfeeding and latching the baby. But even if you've chosen to bottle feed your baby, your body may still bring your milk through over those next 3 to 4 days. So it's important that we also talk to you about your breast too and check that that milk is being suppressed, not causing you any problems with blocked ducts or infection. Sometimes when the milk comes in, women can almost feel like they're getting a little bit of flu. You feel like your temperature's gone up. You might have some night sweats. It's all very normal with your hormone responses that's bringing your milk in. So please don't worry if you're feeling like you're getting a little bit fluey, that fever overnight, that sweat, it's probably your milk coming in, but do talk to us about it because we can check your temperature, make sure there are no signs of infection anywhere else in your body and check that that is a normal process of milk coming in. And if you have chosen to bottle feed, we'll give you advice on how to suppress that with not touching them, good supportive bra to hold them without them being made to feel painful because they're getting a bit full, and how that milk will gradually suppress over the next few days and you'll become much more comfortable. And if you're breastfeeding, we'll be talking about the whole journey of how the latch of the baby is, the condition of the breast, the milk supply, and all of that encompasses with that area of your body. If you would like to know more about feeding, whether it's breast or bottle or expressing and using pumps, that's covered in another section within this pack. So I've not gone into too much detail here, but just for you to know and be reassured, it is one of the main things that as midwives and midwife support workers, we are supporting you with in that postnatal period when you're at home. And I'm going to talk a little bit more about how many times we'll come and see you, but to reassure you that if you're experiencing concerns with feeding, the likelihood is that we're going to see you much more often than the standard routine schedule of visits, because it's one of the main things that we're supporting. So moving on, we might be taking your blood pressure. That might not be done at every check, and it depends whether you've had problems during the pregnancy, but at some point we'll take your blood pressure to make sure that that's all normal. We might take a pulse or a temperature, depending on what you've described to us as how you're feeling, to make sure that you are well and we've got nothing that we're concerned about. It is important to keep an eye out for any infections after birth, and they can come from different areas. Some women can get infections in their breast, sometimes you can get a urine infection, sometimes there can be infections inside the womb, and depending on what you describe to us as your symptoms, if you're not actually feeling very well, we will look at all of those potentials depending on what you've said. So sometimes doing a pulse and a temperature can help us look at whether we think there is an infection or whether actually it's just hormonal, tiredness, or your normal recovery. We will ask you about your blood loss. It's really important that women know that they're going to lose quite a lot of blood after giving birth, and that's after any mode of birth. So whether you have a quick birth, a long birth, a vaginal birth, an instrumental birth, or a cesarean section, you're going to get what will probably feel to you like a very heavy period initially. And sometimes women can actually pass clots during this time. Now, some of those clots are really normal, and it's just where you've been sat still for a while. Perhaps you've done a breastfeed, and when you breastfeed, your uterus is contracting, which is how your body is shrinking your uterus back to pre-pregnancy. So sometimes you've been sat breastfeeding and then you've sat a little while and you've gone to stand up, and where you've been bleeding inside, it's just sat there, clotted a bit. You stand up and out comes this clot. So sometimes it's really normal, but it's always worth giving us a ring if you're worried about the amount you see. But anything that's like 5p, 10p, stringy clots, that's really very normal. But if you're starting to get clots that are sort of golf ball egg size, particularly if it's more than one, then that's something to give your maternity unit a call about, just to talk through that with them and make sure that your blood loss is not too much. It's more common to get those heavy blood losses and clots in the first 1, 2, 3 days, and then you should start to see that blood loss is beginning to get less. You're changing your pads slightly less frequently. The clots are getting much less. And actually that lochia that we call that after blood starts to change a bit as well, from being a period-like blood to sometimes being a bit more watery, pinky red, because you're losing other kinds of fluid from that postnatal period as well as the blood. If in doubt, if worried, feel free to call your maternity unit. Sometimes what's actually quite helpful is if you've had a big clot, but the midwife is due to visit you in a couple of hours and you otherwise feel well, just keep it for us. I know it can seem a bit, but honestly, as midwives, we're very happy to look at clots, dirty nappies, perineums, stitches. We want to know that you're okay. So please never worry about showing us these things. It can be really helpful to actually see the clot, because we can have a look at the consistency of it as well. Sometimes if women have had a bit of problems with their placenta coming out after birth, we're keeping an eye that you actually don't have any still left inside, or any of the membranes of the sac that the baby was in. So if you did have any of those concerns and you then lose something like that at home, keep it, because actually it's really helpful for us to see it and confirm, actually, yes, that's a bit of placenta. Maybe we need to go and get you a scan and just check that there's no more left inside there. Or that's just blood that's clotted. Very happy, not a problem. Immediately after birth, it would be quite normal to have to change your pad every half an hour to an hour for the first few hours, because that blood loss can really be quite a lot. But your midwives will still be with you and you can check with them that it's normal, so please don't worry. Once you go home, or your midwife has left you at home, I wouldn't be expecting you to saturate a sanitary pad every hour. That potentially is a bit more than we would like, and I would want you to call somebody about that. But changing your pad every couple of hours, and then that going to 3 hourly, 4 hourly for those first couple of days, is probably quite normal. But again, if in doubt, then don't worry about giving us a call. You may well be experiencing quite strong period pains, or almost like contractions for those first few days after birth, especially if you've chosen to breastfeed and you get those pains when the baby is breastfeeding. Because what's happening inside is your body, now it's had your baby, needs to shrink this uterus muscle that's grown to accommodate your baby. It's got to get it back to that really small pre-pregnancy size, and it needs a bit of help to do that, and the muscle contracts to shrink. So that contraction that's happening is a little bit like a contraction for when you were birthing. And so you do feel that as period pain, or perhaps some lower backache. So please don't worry about that. That's a really normal, important process that needs to happen, but it can be uncomfortable for you. And that's why having paracetamol and ibuprofen as pain relief options in the house ready can be really helpful to keep on top of that period pain that you might be feeling. And I just want to say as well that that can be stronger each baby you have. So every time you have a baby, your uterus gets a little bit better at it every time, because muscle has memory. So it remembers what it did last time. And that's why birth can get a bit quicker with each baby as well, because we get more efficient. But with that efficiency can come a bit more pain for us. So just keep on top of that with hot water bottles, paracetamol, ibuprofen if you can take those, and make sure you rest plenty. So it's time we talk about pooing and weeing, which midwives always love to do, whether you're pregnant, giving birth or afterwards. It's really important that we know that your body is going to the toilet normally. It isn't going to feel normal to you. And one of the things I really want to reassure you about is that this isn't going to feel right initially, particularly going for a wee. It can feel like you can't feel your pelvic floor after you've given birth, probably more so with a vaginal birth, but potentially even if you've had a cesarean, because everything's been rummaged and it can feel a bit numb and you've been carrying a weight of a baby, and it's going to take your body a while to recover from this. So I don't want you to worry if you find that you can't feel when you need to go, like you didn't realise your bladder was full. That's really normal. I don't want you to worry if you're walking to the toilet and you're going for a wee, but that wee is already coming before you've even sat on the toilet, because that's really normal in the first few days after birth as well. It isn't going to stay that way, and I don't want you to worry. If for any reason that continues, we will get that sorted and seen to very quickly. You just need to talk to your care provider, just talk to your midwife. But for the first couple of days, that's a very normal thing. It's going to get better quite quickly, but you need to give it a little bit of time. So it's really important that you don't let your bladder get too full, but you're not going to really feel when you need to go. So it's a good idea to think to yourself, I'm going to go to the toilet every 2 hours, whether I need to go or not, because I'm bound to need to go, I just can't feel it. We need to retrain the bladder to feel that filling and emptying, particularly if you've had a catheter for any reason. So if you had an epidural or a cesarean, you might have had a catheter, and then your bladder has kind of forgotten what it was doing because that urine's been draining continuously into the bag. So just make sure you think, I'm going to go to the toilet every 2 hours. Obviously not in the night if you're asleep, but every time you get up to feed your baby, go for a wee. Get that bladder working again. Know that if you can't feel your pelvic floor and it feels like the urine is coming quickly, don't worry, that's going to improve of its own as your body recovers and your hormones change, and that recovery can actually take a few months sometimes, so not to worry. But the midwives will be asking you, are you going for a wee? And when you go, is it a good amount? So some women in the past have thought that they were going, but they've only been going a little bit and their bladder hasn't completely been emptying. So we're quite cautious now just to ask you, does it feel like it's a good amount when you go? Because we don't want you to be retaining any urine and stretching your bladder at all. So if you're only going little trickles, but you're drinking loads and you think, oh, I should be peeing more than this, then do tell us. And of course, we want to make sure that your bowels start to open as well. And we understand that this can be a little bit frightening, a bit worrying when you've had a vaginal birth especially, but also with a cesarean, because your bowels have been disturbed during the operation. It can be difficult to go to the toilet for that first poo, and it can sometimes be a bit painful because inevitably, if it's been a few days, we might have gotten a bit constipated, and then that stool is a bit hard and a bit large for us to pass, and we're sore inside. So I always recommend to women to be on top of that very early on in terms of helping your stool be soft, because the softer your stool is, the easier it's going to be to pass, and for wind to pass as well. If you've had a cesarean, sometimes you can get trapped wind and it can be really quite painful. So we want to make sure that not only the stool is passing, but your wind is passing nice and easy too. And if you get constipated, not only will the poo get stuck, but the wind gets trapped too, and then it's sore for you. Movement usually helps us go for a poo, and that's something you're going to be doing not very much of. So just be mindful that you need to use other ways to kind of help it. So plenty of water and fluids, because that will help your stool be soft. A gentle laxative if you need one, if it's becoming quite a few days and you've not been yet, or you want to stay on top of it, or you've needed to use these in your pregnancy because you're already you tend towards that already. Senna is a very good laxative when you've pregnant or had a baby. Some women like lactulose, although sometimes that can make you a bit windy. Sometimes fibre gel sachets just to bulk up that stool and make it softer. They're all really good, and any chemist, pharmacist will be happy to just chat to you about what the right laxative might be if you go to purchase some. So plenty of fibre, plenty of fluids, being on top of that early on. No straining when you sit on the toilet, but if you begin to feel the need to go and sit on the toilet and just allow it to happen. And actually this is where the hypnobirthing breathing can be really effective for you again, because you'll be a bit nervous, potentially a bit anxious. All that down breathing that you did, practice of perhaps during birth, don't forget it, because that's something that can really help your body relax down there. No straining, just allowing the normal contraction process to allow you to go to the toilet. You'll be absolutely fine, and once you've done that first one, you'll be absolutely fine afterwards. So if you've had a vaginal birth, it's possible that you might have some stitches on your perineum. There's a variety of little places that there might have been some traumas. Sometimes the labia might have some stitches in it. Sometimes everything on the outside might be completely fine, but there was a tear on the inside on the vaginal wall. So sometimes the stitches are very internal. And sometimes the woman might have had a tear that has touched on her bottom a bit. So sometimes those stitches are very much external and go towards her bottom a bit. Or you've had an episiotomy and they've made a cut so the stitches extend a little bit out towards your bottom, to your sort of butt cheek. The midwives will be checking the recovery of those at home. We're very happy to have a look. And depending on how you feel, we would sometimes encourage you to have a look yourself. That's very individual. Some women like to be able to look at their own stitches so that they can, over the weeks, see the healing process and they know whether things have got better or they have a concern it might look like it got worse. But not all women feel comfortable to do that. That's absolutely fine. We're very happy, and we will ask to have a check to make sure everything's okay. You can really help the healing of those stitches by preventing infection. So most stitches heal very, very well, providing that we don't get an infection in them. And of course, because we're going to the toilet, that sometimes is an area where it is a little difficult to keep infection away. So really good hygiene is really important. So very good hand hygiene in between going to the toilet and also handling your baby and changing their nappies, so we're not introducing infection between people. Really important that you change your pads regularly so that you're not wet for too long. So lots of changing of pads, and keep to the soft maternity pads. Sometimes women change to like other brands that you would use for your period, but they're a bit rougher on the surface and it can chafe your stitches. So make sure you stick with very soft pads. In terms of comfort, some women like to put slightly damp sanitary towels in the fridge, and then for comfort, to relieve some of the soreness you might feel, take that cold wet sanitary towel and pop it in your knickers. It will warm up quite quickly, but for that 10-15 minutes that coolness is really lovely. You can also do that with flannels. If you put wet flannels into the fridge, they come out really cold, and that can be a really nice compress for 10 or 15 minutes. So in terms of comfort, the pain relief we've talked about already in terms of paracetamol and ibuprofen can be really, really valuable as well, to keep on top of the soreness if you're finding that you are uncomfortable. If you've chosen to breastfeed, or even when you're bottle feeding and you're holding your baby to bottle feed, we're sat on our bottom a lot. So finding other positions where maybe you're just on your hip a little bit, not directly sitting on your bottom if that's sore, or a comfortable cushion that makes it a little easier. So think about your seating. And if you happen to be going out a little bit, lunch or things, think about the seating thing. So some people like to go out for lunch quite quickly just to get out of the house, but then they're sat in this restaurant on a wooden chair, and actually that can set you back because it's not comfortable enough for you to sit on. So if you are going anywhere, just think about your seating and cushions and being comfortable so that you don't make yourself more sore for later. If you do have a tear that makes weeing a bit sore, so if your labia had a bit of a tear and there's some stitches there, or just you might have had a graze, we didn't need to do anything with it, but there's a little bit of graze there, weeing can be quite a stinging sensation. So going for a wee in the bath or the shower can really help. Or if you get a wet flannel, and if you just hold that wet flannel just over the little part, the area of the labia that might be a bit sore, and then wee, you're just protecting the little graze you've got from the wee sitting next to it, which is what's making it sting. So there are little things that you can do for comfort to make all those things a little bit easier. It's possible that you might be told you've got a graze down somewhere on the perineal area. So it's difficult to imagine what that might look like. But if you imagine when the baby's head has come and it's crowned and it's slowly stretched toward that perineal area, if you imagine where the clitoris is, up where the hood of the labia starts. That area there is often where a graze might happen. Women don't feel it happen. It's not something that you're necessarily aware of, but the midwife might afterwards say, well, you have got a graze up at the top. So that baby's head has come and stretched that area, and where that skin is sort of pulled really tight, it hasn't torn, but the surface of the skin has just pulled apart a little bit. And then when the baby's been born and that's all relaxed back down again, it's not a tear, but it's a surface area of the skin that's opened a couple of top layers of skin. And so it's like a surface graze, and it can be quite sore. It doesn't necessarily need any stitches because it's not apart, but it is a little broken on the skin edge. And so it can be a bit tender and a bit sore, particularly when you wee. So it's really important when you go to the toilet that if you're finding it stinging when you wee, perhaps a cold, wet flannel held over the graze and then weeing will make it much more comfortable for you. Or just for comfort when you're sitting, something cold placed against it, like a cold, wet flannel from the fridge. Or you can wet a sanitary pad, pop them in the fridge, take out that and pop that in your knickers as your sanitary pad. And because it's cold and a bit wet, it will provide some comfort for that graze that might be a bit sore as well. Important to just keep them clean and dry, as well as your stitches. So we don't recommend any creams or soaps on any kind of perineal trauma that you might have had. It's just nice warm water, gently pat dry, and let the midwives check that all that healing is happening nicely. When you're taking care of any sutures that you might have on your perineal area, or just for comfort post-birth, even if you didn't need any stitches, there are some products on the market where you can buy sprays and things to help with healing. We don't recommend using anything but water and just gently dabbing the area to dry it. But I understand that many of you might seek out other alternatives, and I would just say be careful with what you purchase. Nothing too strong, not too many chemicals, no creams until things are really, really healed. Some people are inclined to want to use essential oils for healing, like lavender and tea tree oil. And if you were making up any of your own blends, just be really careful with the quantities that you use. If you were going to use lavender and tea tree oil, if you were putting it on your sanitary pad or making up a spray, you would want to be using only 1 or 2 drops of each. When you do that, it's very important that you use minimal quantities if you choose to do that. But we would recommend that you're okay just with water. It's possible that you might be feeling really, really well after birth, and I hope that you are. And sometimes that's quite a lot of adrenaline that's in us still, kind of keeping us really high, and all the joy of your new baby and the desire to show them off to the world and get out and about. And sometimes we can set our recovery back by doing too much in those first few weeks. So I'd really encourage you, even if you're feeling quite mobile, comfortable and eager to get out and about, that you just think twice before you do or what you're about to do. There's a general rule of thumb that the first week should be in bed and the second week should be on the sofa before really you're venturing out too much. If you walk quite a distance, you'll find your blood loss will get heavier and you might feel your pelvic floor become a little sore and tender, sort of internally. If you've got stitches and you do too much walking or sitting uncomfortably on the wrong seating or in different places, they potentially will get an infection or become more sore, and we don't want them to break down and open because your healing will be much longer if that happens. So in order to protect the healing process, it's so important that really for that first 2 weeks, and potentially even longer depending on your own individual recovery, you are really, really minimal with what you do. Just think about how far you're going, how far you're walking, what you can do within the realms of your own comfort, but really, really don't push yourself because you will set your recovery back by quite a lot. It's far better to go very, very, very gently, particularly if you've had a cesarean, because you must remember that even if the outside skin scar looks really beautiful and all healed, you've got loads of internal healing happening as well. Just go really, really gently. And then after that 2 weeks, hopefully you'll be ready to go because you gave yourself that time to recover and heal properly and not set yourself back with any problems and infections by doing too much too soon. Many of you will be worried about starting to have sex again with your partners, and your partners might even be worried about it. This is a really individual time when you've got to do whatever is right for you. couple of things that we would recommend is that you've stopped bleeding first, because what we want to avoid is you getting any kind of infection. So waiting until you finish bleeding, and absolutely waiting until you've healed if you had any perineal trauma, is really important. But once those two things have happened, it really is entirely up to you as to when you feel comfortable. And one of the things that I would always say to the woman that particularly when I'm discharging her, one of the last things I'll say, because I'll offer to do it with her, is for you to feel comfortable to have sex again with your partner, you need to feel comfortable with your own body. And one of the ways in which we can do that is to be familiar with our bodies. And so I don't want any woman to ever be afraid of what she might look like or feel like within that part of her body after giving birth. Because in your head, it'll be so much worse than it really is. If you had an episiotomy or an extensive tear and you're worried about what it looks like, honestly, I can say to you, when you come to have your next baby and give birth again, I can't even tell. As a midwife, I so very rarely can even tell whether a woman has had a tear before or at any other time, because I can't see it. We heal so beautifully down there because we have such a good blood supply. And if you take care of it after having your baby, the healing is so good, you very rarely can ever tell it ever happened. But you will notice the subtle differences if you're quite familiar with your body. And it's really important to become familiar with your body again, so that you can comfortably be intimate with your partner and feel okay with that. So I would encourage you, either on your own, with your partner, with your midwife, to feel, to have a look, to check when you're ready, what you look like there, how it feels, particularly because if there is an area that is sore, if you've healed but there's some scar tissue there that is a bit tender, we can do something about that. Your GP can refer you to be seen by somebody who can potentially prescribe a cream or a way to massage that area, which can actually break down that scar tissue and make it go away so that you are comfortable and there is no pain. So don't ever sit with something, because we can so very often do something about it. But become familiar with your body, become comfortable within yourself, and then you will feel like you can be intimate with your partner again. But it needs to be on your own terms and when you're ready. And the chances are the first time you have sex, you will be anxious. So use a lubricant. Don't be dry, because you will be sore. So use a lubricant, avoid that issue, make it comfortable, and build on from there when you're ready. As well as talking about the healing of that area, and regardless of the mode of your birth, so if you've had an abdominal birth with a cesarean, your pelvic floor exercises are a really essential part of your recovery. I'm not going to talk too much about that because I know there's a section within this pack from a physiotherapist, but just to say that you really do need to do them, and you need to do them for the rest of your life. When we go through our menopause and our hormones change, this relaxation of our muscle later in life is going to bring out any areas of weakness that you've got. So the more you can do now to improve your muscle strength over the next few years, the better your menopause is going to be. Women very rarely talk about menopause, but that's something that we need to think about too. If you're struggling to remember to do your pelvic floor, if you can't link it to something like when you feed your baby, there's a couple of good apps on the market where it will ping your phone and remind you throughout the day to do 5 minutes of pelvic floor exercises. And if you're worried about whether you're doing them properly and you want a bit more individual assessment or advice, please don't hesitate when you have your 6-week checkup with your GP to ask them to refer you to a woman's health physio. That can happen through your NHS referral, and they will see you, assess your pelvic floor, assess how you do your exercises, and guide you to make sure that you're doing them as well as you can. When it comes to thinking about contraception, it's really important that you and your partner have a discussion about your family planning intentions, what the right thing for you might be, but there's plenty of options available to you. Obviously, you've got condoms. There are contraceptive pills that women can take even if you're breastfeeding. Marina coils are a very popular contraceptive method at the minute, and often women might get them popped in when they have their 6-week GP check, or perhaps you'll do a smear test, which can happen from 12 weeks after birth, and you could combine the two then. But what's really important is that you go and speak to somebody, whether it be your GP or a family planning service, with all of the knowledge of what you can take and make a decision that's right for you. But it is essential that you do think about your contraception if you don't want to plan a baby soon after having given birth, because you will ovulate before you get your first period. So sometimes women think, I'm fine until I get my period. but your egg comes first and you will never know when that is going to happen. Breastfeeding exclusively is not protective. Many women have exclusively breastfed and then conceived accidentally, not knowing that they've ovulated. So please don't think that you're protected. Use contraception if you're not planning another baby. And I just want to say, if you've had a complex birth, particularly if it was a cesarean, we do recommend a 12-month recovery gap, particularly if you've had a cesarean section. That wound on your uterus needs to be very well healed and strong to support another pregnancy and for you to have a safe birth the next time. So do talk to your care providers if you've had any complexity in your birth around what kind of a gap you might need to leave before trying to have another baby. When you become pregnant, women are actually at a little bit of a higher chance of getting a deep vein thrombosis, a blood clot. So like the things we talk about when we go on long haul flights and we're trying to protect ourselves, when we're stationary, not moving very much, and our blood can clot and we get this clot that might travel elsewhere in our body, it can be really dangerous for us. When we're pregnant, our blood is just slightly thicker, we have more volume, we are at a slightly increased chance of developing those blood clots. So you might find that people assess you for that chance individually throughout the pregnancy, and there are occasions when women are asked either to take aspirin or to actually give themselves a once-a-day injection, which is a blood thinner as a drug, to protect you from those blood clots developing. This particularly happens after birth. So after birth, all women are sort of assessed for their chance of developing this blood clot. And some people have a higher chance than others with your individual factors. For example, if you've had a cesarean section, or you've had a blood loss that was over a litre, or we think you're going to be more stationary than someone else, these may give you more chances of developing that blood clot. So we're going to ask you about the signs and symptoms. So one of the things midwives will ask you when you're back home is, how are your legs feeling? Are your calves comfortable? Are either of them swollen, hot, red? Have you had any chest pain or sudden breathlessness when you've been sitting still? And those are all questions around, are we worried about a blood clot? But you might also have found that when you were discharged from the hospital, one of the drugs you were sent home with was this one-a-day injection. So after the birth, the midwife will do this assessment. Are you at an increased chance, and would you benefit from a week or potentially longer of taking these once-a-day injections? And if you are happy to have those injections, if you've been recommended them, you'll be shown how to give them. Either you or your partner or another support person can do that, and the midwife will support that in the home environment as well. But it's important that you're aware of the signs and the symptoms, so even if you weren't recommended that injection, you are monitoring that your legs feel comfortable, there's no hot, swelling, soreness that you want to report to us, no breathlessness when you're sat still, and no chest pain. But also just to say, please don't panic if you feel a bit breathless, because that's quite normal after birth. If we've had if our baby's been pushed up underneath our lungs, especially if you've carried more than one baby and you've had twins or triplets, sometimes our rib cage has been pushed out where that uterus has grown and the baby has taken up that space. And after the birth, because everything suddenly decreases quite quickly, women can feel like they can't quite catch their breath after birth. Like you're breathing in, but it almost feels like you're not, and you can't. This is normal. Please don't panic. If you're worried about it, the staff will check you out, make sure everything's okay, check your oxygen, make sure everything's all right. But it can be a bit normal initially to feel like you can't catch your breath. And also when you walk up the stairs, we're inevitably going to feel a bit breathless, particularly if we've had a high blood loss. Or if you had low iron levels, you were anemic in your pregnancy, you might be a bit more susceptible to that, feeling that bit of breathlessness. So don't assume if you're breathless you've got a blood clot, but do definitely talk about it with your care providers. It could be that you just perhaps need some iron tablets, or you're not resting quite enough and actually everything's okay. So once we know that you're okay, then we're going to move on to doing lots of discussion about your baby, which I know is probably preoccupying the most of your mind at the moment. It's really important to touch base with yourself and your own self-care as well as your baby, because a well and happy mother equals a well and happy baby. So don't be afraid to sit and consider your own needs. But now we'll go on to talk about your baby and everything that they need as well. When we're coming to see you at home, once we know that you're okay, then of course we want to know if your baby's okay. And the way in which we tell if a baby is well is with a few things. Are they pink? Are they warm? If when I disturb them, do they respond with maybe crying, good muscle tone and movement in their body? Are they weeing? Are they pooing? And are they feeding? And that's our assessment of a baby. There are other things as well that we might be taking note of. What's their eye condition like? What's their cord healing like? So there's a few other things, but the general well-being of a baby is, are they warm? Are they pink? Do they have good muscle tone when you disturb them? Are they weeing? Are they pooing? And are they feeding? And that's the kind of phrase of our discussion when we're going to be asking you those questions. You are likely to be quite tired from the birth, however that may have happened, and those preceding few days. So sometimes it can be a good idea to jot down wees and poos and feeding, because it can all get lost in a bit of a haze of your tiredness. Now you can do that on paper, or there are some apps which are quite useful for jotting down feed times and poos and wees, because then when the midwife comes or the support worker and asks you about the last 24 hours, it's all down in front of us and we can just have a little assessment. You will have been sent home with some guides to what is normal in terms of our expectations. So within your leaflets and documentations, you probably have some paperwork that says in the first 24 hours we'd expect this many wees and poos. In the second 24 hours, at 72 hours, this many wees and poos, when we're expecting the poo to change colour. So if you've done the antenatal classes or you've got friends who have had babies, you might know that the baby's poo is initially called meconium, which is this black marmite tar-like substance which the babies will clear out and then transition to the milk poo, which is much more of a yellow, korma, seedy, very, very wet, loose experience. So that transition would usually happen within the first week, can sometimes be a bit delayed without there being a problem, but these are the questions the midwives are going to be asking. So jotting some of these things down can help where you're tired. How often is my baby weeing? Does that nappy feel heavy with that wee, or is there no weight to it? Can I see that that urine is pale, or is it quite a strong orange colour? So we're kind of looking at how dilute it is and how hydrated the baby is. How many poos have they done? What colour is that poo at the moment? Have they started to make the transition to a brown, a more yellowy poo, or are we still kind of blacky green? And how frequent and how much are they doing? Is it a 2p coin size of poo, or is it the whole nappy? So that assessment of their fluid intake is really important. If the baby is pink and warm and waking on disturbing with good muscle tone, regardless of whether the feeding is going well or not quite well enough yet, that baby's currently well, and we know that we've got time to continue to support the feeding, hoping that that urine volume and that poo output is going to continue to get better. But if we have a baby that's becoming to be a bit floppy on disturbing or sleeping for very long periods and is difficult to wake, perhaps is not as pink as we'd like and is more of pale and is finding it difficult to maintain their body temperature, that's a baby that needs a proper reassessment, because perhaps they've not been getting the milk that maybe they've needed, or maybe their jaundice, if they've got any, is a problem. I'll talk a bit more about jaundice in a minute. So the baby that's pale, not maintaining their body temperature is called to the touch, is sleeping for extended long periods and is difficult to wake and is relatively floppy with their muscle tone, that's a baby that needs to be seen and reviewed and checked out. Now, the support that you're getting at home or in your postnatal clinics is hopefully going to prevent the baby getting to that stage, because we've already seen that perhaps there's a problem with the milk quantity or the feeding or the baby's wellness, because there are sometimes reasons that babies can get infections, And even if they're feeding really well, if the baby was to get an infection or become unwell with something, they would exhibit it in this same kind of way. So it's not always about milk quantity or feeding that the problem is. So for example, babies can sometimes, rarely, doesn't happen very often, but sometimes get an infection from their cord. So the cord healing, keeping that hygiene, that cleanliness is also really important, and I'll talk a bit more about that in a minute. So that's our general observation of a baby, this colour, warmth, muscle tone, and then talking with you about that output of urine and poo and feeding, how often they're feeding, if they're bottle feeding, quantities and timings, and if they're breastfeeding, obviously we don't know what they take in terms of volumes, but how are the mother's breasts feeling? What is their output like? What's their behaviour like? How often are they feeding for? What does the latch look like? That whole assessment helps us know whether those feeds are adequate for what those babies' needs are. So after the midwife or the support worker talked you through all of those things, and we've got a baby that's warm and pink with good muscle tone, is feeding well, however you might be feeding that baby, we'll also look at what I described earlier as something called jaundice. And this is whether your baby looks like they've got a suntan, a bit yellow. Sometimes they can even look a bit Bart Simpson. That jaundice can get quite substantial in some babies. And in other babies, it's just a coming and going of, oh, I think they look a little bit yellow. Oh, now it seems to have gone. Oh, no, it's back there again a bit. It ebbs and flows, jaundice. So it's very common throughout the period of a day to think, oh gosh, you're quite yellow there. And then in another light or just after a feed, it seems to have gone a lot. So it does come and go a wee bit. You're constantly thinking, yes, it's there. No, it isn't. Jaundice is the process of the baby changing its fetal blood cells to adult blood cells. And it's a very normal physiological process, but it can sometimes become a problem if the baby doesn't get rid of it. So they're changing their blood cells from what they had as a fetus into what they now need now that they're living on the outside. So because they're breaking down the old blood cells, there's like a byproduct of that breakdown of a substance called bilirubin. Bilirubin is excreted in a baby's urine and its poo. That's how they get rid of it. But while it's waiting to be excreted from their body, it just deposits itself underneath our skin, and that's what gives us the yellow appearance when our bilirubin is just waiting to be excreted. So when a baby is feeding well, that bilirubin will be leaving their body through their wee and their poo. But it takes a little while for that process to happen, so they will have this yellow appearance while that process is taking place. And typically babies start to look like they might be going yellow if they get jaundice on about day 2, day 3. And so the midwife is definitely coming around that time and assessing with you whether your baby's getting any jaundice. Not all babies get jaundice. Some babies get it quite substantially and others just a little bit. Doesn't necessarily mean anything. They're all going through the process, but it all gets exhibited in different ways. What we worry about is if that baby's actually not feeding very well and it's not getting rid of that bilirubin in their wee and their poo, those bilirubin levels get higher and higher and higher, and there does come a point where that bilirubin can enter the baby's brain and that baby can actually become quite poorly. The signs leading up to that would be noticing that the baby's not feeding very well, so assuming that that potentially is going to be a problem because they're not feeding, so we're mindful. So not seeing much urine output, not seeing much poo output, being a bit worried about the feeding, we have to think at the back of our minds, we want that to be happening well because we don't want the jaundice to be a problem. But also if you notice a very, very sleepy, floppy baby, sometimes that can be because the bilirubin levels are getting a little bit high and we need to put an intervention in to make sure that baby's feeding well enough for that not to be a problem. And of course they might be looking like they're getting more and more yellow as well. We can do a test to read their bilirubin level. We can do a little prick on the baby's heel, take some drops of blood and run it through a machine, and it tells us what their bilirubin level is, so we can check if a baby's okay or whether it's a problem we might need to do some extra treatment. So we can check your baby's well-being if they do go quite yellow. But their behaviour is a really good sign as well. So if we get on that quite early in terms of, well, let's make sure the feeding's going well, let's make sure that urine output and that poo output's what we want to see, let's make sure that baby is alert and active with good muscle tone and isn't too sleepy and isn't too floppy, then we're assessing that right from the beginning. Should at any time your baby be quite yellow from jaundice, or have had a bilirubin blood test and the levels are quite high, please don't worry that that's going to mean that it's gone into your baby's brain and it's a really big problem, because we are preempting it all the time and we have treatment available to reduce those levels really quickly. So actually, one of the things that you can do at home to help is expose your baby to sunlight. Now, obviously, we need to be very careful about sun exposure, baby's delicate skin, but perhaps on a nice sunny day, through the window, 10 minutes in the sun in just their nappy, through that window, that UV light is going to help that breakdown of the bilirubin as well as feeding. So that can really help. In the absence of a really lovely sunny day, or if the bilirubin levels of your baby are quite high, you might have seen that babies can be put under the phototherapy lamps, so this kind of ultraviolet blue light. Please, again, don't worry if your baby needs this. It works really quickly. It's just helping the bilirubin to break down. It's supporting the baby to do it with them. So if your baby isn't able to feed very well at the minute, or the feeding needs a bit more time to establish, as well as the feeding helping to get rid of that bilirubin, we can help with the phototherapy lamps. And the baby gets a nice chill out under a nice warm lamp for a while. They will wear these protective eye masks so that that UV light is not affecting their eyes in any way. But generally, babies are very happy and comfortable underneath those lamps because they're so warm and cozy, which, as we know, they love to be, having just come out of your nice, lovely, cozy, warm womb. So there are treatment options available. It does mean you need to be in hospital if we need to use the phototherapy lamps, but that baby is then in the best place to make sure that bilirubin isn't going to be a problem for them long term. 12 hours often is all the baby needs. It can have longer if it needs to, but it's very easy to help that bilirubin level break down if we need to. As part of making sure your baby is well and in assessing that feeding journey, we will be weighing your baby. Every hospital potentially has a slightly different guideline of when they might offer to do that, and it's also in discussion with you and how you feel about it. But most babies will be weighed, if not already, by 5 days. So if they've not had a weight by 5 days old, when we come to do the blood spot test, we'll also do their weight for you. It's really important to know that we are expecting your baby to have lost weight from their birth weight. It's really normal. It happens whether you are breastfeeding or bottle feeding, and we are happy to see up to a 10% loss in weight without necessarily having to make any changes to what you're doing, although we will do a whole assessment to make sure that everything is looking good and we're not going to expect any further weight loss. So up to 10% loss in weight is really normal on day 5 of your newborn baby, regardless of how you've chosen to feed them. After that, we will generally weigh your baby again on day 10, which is often the next time we come, unless we need to do a visit in between to support feeding if there's been some complications with it. So then again, 5 days later, hopefully we'll start to have seen a gain on whatever their weight was on day 5. But it can actually be static at this point, particularly if you're breastfeeding. So in my own experience as a community midwife, it hasn't been unusual to see the initial normal weight loss and then for it to take a little while for that particularly breastfed baby to start gaining back again. As long as they've not lost more or lost more than their 10%, they're feeding well from what we can assess. They're weeing and they're pooing, that urine volume is increasing, that poo colour is changing. As long as we can see all of those good things, we can see that baby is warm, pink, alert, feeding frequently. I wouldn't want babies, particularly if they're breastfeeding, to necessarily go much longer than about 3 or 4 hours without feeding, although this varies, and again there's more information in the section in this postnatal digital pack on infant feeding. But we are probably demand feeding the baby, but without letting it go too long. So in a 24-hour period, if a baby was having about 7 or 8 feeds, regardless of when they might have taken them, that's usually a good number. So if these things are happening, baby's weeing well, it's increasing, poo's changing colour, that static weight that we might find is not necessarily anything to worry about, and you just might find that the baby's still transitioning, their gut's maturing, particularly if they were born a little early. So if a baby was born at around 37, 38 weeks, perhaps their gut had a little more maturing to do. So that static weight period doesn't necessarily worry me, but we will be coming back to then reweigh and reassess and keep going with that journey. I've mentioned already that sometimes babies, rarely, can get infections, and sometimes the source of that infection can be their healing cord, where the umbilical cord has been cut and come off. So you will probably find that you've got a small length of cord with a plastic clamp on it. Some hospitals offer to remove that clamp, particularly if it's close to the baby's skin, and others leave it on. That varies a little. You can ask if you have a preference for it to be taken off, but sometimes leaving it on can actually aid the dropping off of that cord. That length of cord that's left is going to take somewhere between 4 days to 2 weeks to drop off, a kind of normal length of time. It's really important that you don't do too much with that cord. Some families have in the past put certain ointments and things on, but we recommend not doing anything unless it needs cleaning, and then we would just advise you to use some cooled, recently boiled water. So in terms of bathing your baby, actually we would say don't bath them until that cord has fallen off, because if that cord does get regularly wet and soggy, it will smell really bad and potentially rot a little bit more than it would ordinarily. We would suggest keeping it nice and dry until it falls off. Bathing your baby is not something you necessarily need to do immediately unless they do have a lot of blood and poo from the birth on them, but then just do that one-off bath. Make sure that cord is nice and dry afterwards, and then wait for that cord to have dropped off and for the belly button to be healing before you do any kind of regular bathing. Baby's skin is very sensitive anyway, so regular bathing will often dry it out, so you don't need to worry too much. And it might just be that their hair needs a wash rather than their whole body, and then you can just wrap them up nice and warmly, and using a bowl of warm water perhaps just do their hair rather than their whole body. So keep that cord nice and dry and clean. Get the midwives to show you how you might be able to do your nappy by folding it underneath so that the cord can sit above it and it's not being pressed on into their tummy by the nappy. So if you put your nappy on completely as normally, but then fold the top down, it might sit quite nicely underneath that healing area so that it's not under any pressure and it's free to the air if you're doing any nappy time or just with the baby grow over it. So clean and dry. It will go mucky on the inside of where you're going to imagine that belly button is going to be. So we're happy that it might go a bit scabby, a bit wet, where it's rotting to fall off, which is essentially what it's doing. It might get a really bad smell. We will check this when we're coming. When there's an infection, what tends to happen, you will start to see an area of redness on the skin around the edge of the belly button. So if you've got a patch of red creeping out across your baby's tummy, that is probably something that we need to get looked at. And that's what the midwives are assessing when they're also coming. So one of the reasons why we tend to always strip your baby off when we come to do a visit, even if we're not weighing them, is because we're just having a general look at them, but particularly at the cord area. Should your baby's cord have any infection, please don't worry. It's often very easily treated with some antibiotics. Sometimes those antibiotics need to be given intravenously to get on top of the infection, which might mean going back into the hospital for a couple of days. But please don't worry, those antibiotics work very, very well and will clear that infection right up. One of the other things that you might want to consider, particularly if you're not going to be bathing your baby yet for a few weeks, is other areas of their body that might need cleaning. You'll be doing the bottom because of their nappy changes. We've talked about cleaning their cord area. Now the other place where they can get some mild infections is sometimes their eyes. Babies can sometimes have immature tear ducts that can get a little blocked easily. So you might find your baby has quite watery eyes, both of them or one of them. This can lead to sleep accumulating in them, so their eyes can be a bit mucky when they wake from a sleep. It's often not an infection, but sometimes it can get to that level if we don't routinely and regularly clean it. So when it comes to the eyes, we do recommend cleaning those every day. And what you would want to do is be careful of cross-contamination, so separately clean each eye. We just advise cotton wool and water. You can use cooled boiled water if you're worried that there is a bit of an infection building, just to keep everything as clean as possible. And we would recommend that you clean from the inside of the baby's eye to the outside, taking any infection away. Drop that piece of cotton, get a new piece if you need to do it again. so that you're keeping it as clean as possible. Some of you might like to try cleaning with breast milk. So if you've chosen to breastfeed your baby, you could express some of your milk onto the cotton wool. There's so many antibodies in breast milk that if there is a little bit of an infection or some bacteria building, that breast milk might actually get rid of that bacteria for you because of the antibodies. So you can clean with breast milk as well as cold boiled water. But it's just important to keep a general everyday observation of those eyes, give them a clean, and just check in with us if you're worried about them in any way. You might find, as you're looking at your baby daily and changing them, that their skin has lots of potential red marks on it sometimes, or little rashes that crop up, and particularly near the birth afterwards, you'll notice perhaps this thick, white, creamy substance that might be on a great quantity on some babies and a very little on others. And particularly you'll find in their creases, underneath their armpits, between their legs. So that white substance is called vernix. Because your baby has been in fluid for such a long period of time, to protect the skin from being in fluid for so long, this thick creamy vernix is this protective layer. And depending on when your baby was born, they'll have more or less of it. So the more a baby comes up towards its due date, the more of its vernix it will have absorbed into its skin. And the earlier a baby is born, the less absorption will happen, so the baby can be a bit more covered in it. It is the most amazing moisturiser. Please don't feel that you have to wash that off of your baby. It will absorb into your baby's skin and it will form a nice moisturising protective element to their skin. Also, please don't worry if your baby does get very dry. So some babies, particularly if they went quite over their due time, do get very, very dry, scaly skin, especially in their creases. So you'll notice around their wrists, their ankles, where they crease their tummies, they might go really flaky. You don't have to put anything on your baby's skin. You can just observe, leave, that skin will come away and they'll have nice, healthy skin underneath. Although you don't need to put anything on your baby's skin, you will notice that there are products that are available for baby's skin and bars and things. So we don't necessarily recommend that you need to use anything, but if you did want to, if you felt your baby was very dry and you wanted to do some baby massage, there are products that are more organic and natural than necessarily some others with chemicals in. So we would just recommend that you went for a very basic product without too many chemicals in, where their skin was unlikely to react too much because they are extremely sensitive. And certainly I would do one try of something without potentially always using it, because you might want to just see how your baby's skin first after one use before you use it routinely. But we certainly don't say you have to use anything. And some people actually will just use a very basic oil, like an olive oil or a coconut oil, rather than buying any expensive brands that have got more chemicals in. So just be careful around what you're putting on your baby's skin and don't feel that you have to. Thinking about some of the things we discussed during the section on the fourth trimester, if you're looking at ways of comforting your baby, one of the things that you will have come across probably from friends or things you've read online is something called swaddling. And in fact, you can buy swaddle blankets or zip up swaddles now, different ways in which to do this. What I mean by swaddling is that you use some form of material in some way to hold your baby tightly, so their arms down by their sides, so that they're not able to escape their arms, in a way of recreating that coziness and tightness that they have felt when they've been inside of the womb. If you look at the Lullaby Trust and safe sleep guidelines that are available, it will recommend not doing swaddling. But I also recognise that many families will try this because it can be very challenging when a baby is difficult to settle and has periods crying, and you want very much to calm and reassure your baby. And some of you will try swaddling or have been given these swaddle blankets. So I want to talk about it, because if you are going to do it, then there are some things to be mindful of in order to keep things safe. So one of the reasons we might not recommend swaddling is because it is possible to overheat your baby by doing that. So the general rule of thumb is to have the room temperature that your baby is sleeping in at between 16 to 20 degrees Celsius, and perhaps to consider the rule of thumb that dress them in the number of layers that you require and then just give them one more. And the important thing to remember with a swaddle, depending on how you're doing it, is that if you're using a piece of material, what is that material? Is it a muslin or is it a thick blanket? So think about what you're using in terms of its thickness and its heat that it will keep in. And then if you're doing one side and then doing the other side and then wrapping the feet up and around, think of then how many layers have I provided that baby with? So when it comes to swaddling, just think about those things. So if we're in the middle of summer and it's quite warm and maybe you've just got your baby in a vest because it's quite warm, you wouldn't want to be doing a swaddle within a thick blanket. You perhaps would want to use a muslin, and just be careful how many times you are wrapping those layers around your baby. As well as thinking around not overheating them, we also want to be careful that we don't provide any material in a way that might rise up and above your baby's face, because what we want to avoid is any risk of suffocation, which is why we recommend that when you put babies down on their back to sleep, that we would put feet at the bottom of the cot or the Moses basket, whatever you're using, because then they won't crawl and slide down even further and go underneath their covers. So loose coverings can be a little bit tricky, just be careful. So the swaddle needs to be something that isn't going to end up covering your baby's face because of that chance of suffocation. Swaddling can be a really good way, some families have found, at helping your baby feel safe and secure and sleeping in. So although we might not recommend it, it might be something that you choose to do, and that's absolutely fine, because these are all choices that you've got. Despite there being guidelines and recommendations, we also want to help you build your confidence in your own instinct to know what your baby needs and what is going to help your baby settle and be calm and feel safe. So if you choose to do swaddling, we just want you to consider how to do that safely. It's really important that one of the things you always remember, as well as your hypnobirthing breathing techniques that I believe really carry on and help within this period where you might have challenges around sleep deprivation and an unsettled baby, always remember how to take yourself to a calm place. But one of the other really important things to remember is when your baby is unsettled, or when you're having challenges with feeding, regardless of your choice of breast or bottle, skin to skin is always a really good go-to with your baby for calming you both down, resettling them, helping their heart rate calm, come in line with your own breathing, as long as you've found your calm center as well. Developing that bonding again, stimulating feed behaviours. So just never forget that early skin to skin that we recommend post-birth is not something just for that first few hours after birth, but something to continue between the baby's main care providers and that baby for as long as you want to do that. Never forget that stripping down together and going skin to skin can be the answer to many unsettled an hour or two that baby's having. I'm not going to talk too much about how you help your baby sleep in this section, because in this postpartum pack you've got a whole section devoted to sleep. So if you'd like to know more about that, then I'd recommend you go and watch those videos. As well as checking the physical well-being of you and your baby and talking about the infant feeding journey, there's also some screening tests that we're doing as midwives and support workers. At your very first booking appointment when you were pregnant, you may have been given the screening booklet, which talks about all of the screening throughout the journey of having a baby. But if you didn't, or you're not sure of the web address, in the additional resources PDF document related to this section, I've included the website address so you can look for more information on this. But one of the screening tests that is done in the newborn period is called the blood spot screening. And that is taken when your baby is day 5. It might happen on day 6 or 7, but the optimum time to do it is on day 5. So whatever day of the week that might fall on, you'll get an appointment either at home or in the clinic, and the midwife will come, do the rest of her assessments, but also do the heel prick test, which is the blood spot screening. So the midwife is going to need to take 4 large droplets of your baby's blood, which drop onto a bit of absorbent cardboard on a test paper that she carries. So she'll ask you to make sure on that day that we're going to do this, your baby's foot is nice and warm. So she might ask you to double sock your baby's foot in preparation that day, so the baby's foot is nice and warm so that we have a good blood supply. We have a little device, we hold it to the baby's heel, and it pricks the baby's heel in a way that then allows some drops of blood to fall. We will often encourage you perhaps to feed your baby while we're doing this test, bottle or breast, because sometimes while they're suckling, this test can be less traumatic for them and they might cry less. But if you're happy to hold your baby while we do this, that can be really helpful to comfort them. It's very quick, doesn't cause too much pain, but it might distress them a little. We will then hold the baby's foot still, which is sometimes the bit that they hate the most, is trying to hold their foot still because they're kicking so much. We take our piece of paper and we just catch 4 drops of their blood, and that card is then sent away to a laboratory that does all of our testing for us, and it's checking for some genetic conditions where you can find more information in the link in the PDF document, but checking for some genetic conditions that we're screening for. All very, very rare, and if the parents themselves are not carriers, it's very unlikely your baby would have any of these, but we're checking for them anyway, because once we know that babies are affected by these conditions, the earlier we start treatment, the much better they do, particularly as adults, but it's highly unlikely that your baby would have any of these. When the midwife is seeing you at home, you might find she checks your paperwork and asks you about how your baby received the vitamin K, if you were happy for them to have that. So if you've had your antenatal classes, you'll know that we offer babies a dose of vitamin K shortly following birth. We recommend that that's given as a one-off dose via an injection. They have it given in their thigh, in an intramuscular injection in their thigh. There is a very rare clotting disease that some newborn babies can be born with, where they're not able to clot their blood properly and they can have internal bleeding. It's very, very rare, but it can be very serious when it happens. Vitamin K is one of our clotting factors that helps prevent that, and newborn babies seem to be born deficient in this. It is in formula milk. It is created through breast milk, so babies when they're feeding are receiving some of this vitamin K, but they are deficient at birth, and so we recommend giving them a dose to help protect against any bleeding issues, particularly if your baby may have had any bruising that's occurred through the birth process, which can be fairly normal when they're coming up against the bony pelvis of the mother and things like that, or an instrumental birth. So we recommend a dose of vitamin K after birth by injection, but there is an alternative option of giving it by oral drops. It's not recommended because we're not sure if the baby absorbs that in their gut as well as they would if they were getting it through the intramuscular injection. So we're not totally confident that that dose goes through the absorption of the gut in a quantity that we need it to. And they also have 2 further doses as well. So you've got to remember, if you do oral vitamin K, that we still need to do 2 follow-up doses, one at about 6-7 days of age, and then again at 28 days. So that's just really important to remember if you opt for the oral route rather than the injection, if you're happy to have vitamin K. I just want to mention about vaccines, because some of you, depending on what hospital you're booked at, will be offered your baby's very first vaccine before you're discharged home, which is the tuberculosis BCG vaccine. Depending on the area you live in, because there's been some increasing rates of TB in community settings, babies have begun to be offered this vaccine at birth in order to protect them as soon as possible. So your baby's first vaccine is available to you potentially, depending on where you give birth, very early on. But the majority of the baby's vaccines are recommended to start at 8 weeks. Strongly recommended that your babies go through the vaccination programme, but of course it requires the consent of the parents. And if you guys are not sure at the moment whether you want to vaccinate your babies, I would strongly recommend that you speak to a health professional to get more information about it, because we have found that we've got some increasing rates of measles in our community recently, and we do strongly recommend this vaccine programme. So if you're not sure, please do go and seek out some more information to help you make your decision. The health visitor will go through that vaccine programme when she comes to see you at home on around day 10, 2 weeks after birth. But if you want to have a look as well, the red book that you're given, which is your baby's health record, that red book has a section on vaccines, and it gives you the whole schedule, when they start, when the boosters are given and what's given. And then if you have any further questions, there's a lot more information provided by the nurses in your GP surgeries, who typically are the ones who will provide and give those vaccines. 8 weeks is the first doses, and then after 4 weeks, 12 weeks and 16 weeks, they're follow-up vaccines. Having very recently given birth to my first baby, it felt like a really good opportunity to sit here and talk to you about my own recent experience. But it's really important that you hear it as that, as just my own experience. There are many different experiences. It's very important we don't compare ourselves to each other, but I have found it useful sitting and listening to my friends' experiences and asking questions. So I didn't want to not talk about my own experience, but I just want to say it is just my experience, and this doesn't mean that this is how it's going to be for all of you. If you find it difficult talking about your experience, or you've got questions you feel embarrassed to ask friends or family or even your midwives, although I hope you don't, but if you did, with this postpartum digital pack comes access to a private Facebook group where you could out there ask any of the questions that you've got, to get responses from other women going through this at a very similar time to you or very recently. So do feel free to use that as an option if that would be more comfortable. It does feel really important to me that as women we perhaps do talk about these experiences a bit more than we do, because even as a midwife, with all the knowledge and experience I have, I felt a little underprepared for some of the challenges that I faced in my own postnatal period. So I think us talking with each other without judgment or without making decisions for one another is a really important aspect of our recovery and our experiences of becoming mothers. So my daughter was born very normally in a water birth experience, and I chose to come home after about 6 hours from the local birth centre. I was very lucky. I had midwives who were going to see me for my postnatal period that had been there for me antenatally and in my birth, my colleagues and my friends. So I was very lucky to have that continuity from people I knew and trusted and felt safe with. And I would encourage any of you to ask your local hospital services if that option is available to you as a woman. Can you have a midwife that you can know through the whole pathway, or at least maybe not for the birth, but for the antenatal and postnatal period? Can it be somebody that you know? Because I think that goes a very long way to feeling able to share our stories and our experiences and get consistent information and continuity through whatever individual journey we're experiencing. I had a labial and a perineal tear, which at the time when it happened, I found the suturing experience really comfortable. They used some local anaesthetic. I used a bit of gas and air. That bit that I'd been a bit worried about as a woman, about having a tear, was actually really, really fine. But in terms of my recovery from that birth, maybe just what my body had to do to open to give birth to a baby, plus recovering from those few stitches I had, for me, I actually found that recovery took longer than I thought it would. I was very, very good at setting up, from the knowledge I've got as a midwife, a very good support network at home. I actually don't have a partner, so my daughter has been donor conceived through IVF, and so my support network was even more important to me, knowing that I wasn't going to have that partner at home with me. So I stayed with my mum and my dad for what I thought was going to be a week to 2 weeks, but turned out to be 3 to 4 weeks after the birth. I had my huge nighttime snack bag ready. I had somebody that was going to plonk cups of teas and meals down in front of me, so I didn't have to worry about making myself food. I had all those things that I know to be important all set up. Food, limited visitors initially, nothing that I had to do, nothing I had to go to, no events I needed to be ready for. I made a choice to breastfeed. I had my parents there and a couple of close friends and my midwives who were going to support me through that period. So I did all of that to set up the best support network that I could. I don't have any other children, so I didn't need to think about who was going to look after them. But for those of you that are having second, third, fourth babies, do think about who might do the school run for you, who might take them out for a couple of hours, because I can imagine that gets more challenging the more children you have in terms of being able to relax and recover. So with this being my first baby, I didn't have to make those allowances. And setting myself up to be able to be looked after in that way actually turned out to be one of the best things I'd done, because I actually found it very difficult to mobilise for a good couple of weeks, because for whatever reason I was really, really sore on my bottom. And whether that was the stitches or whether it was internal bruising or what it was, I don't know. It was a really normal birth, quite straightforward, quite quick. I gave birth within about 12 hours. She was born into the water. Not particularly any complications, but I was really sore afterwards. So some of the things that I've talked about in these sections about cold, damp sanitary towels out of the fridge, regular paracetamol and ibuprofen, finding comfortable positions that I'm not necessarily sitting on. These things were all really, really, really important for me because I was actually quite sore. Because of the heavy blood loss initially, I got the tenor large pants for women. So for those kind of incontinence pants, the ones that are a bit like children's Huggies that you pull up, they were really soft and really comfortable. It meant that it didn't matter how much blood loss I lost. It held it all. It didn't leak. I put a sanitary pad in them as well, so that I didn't have to change the whole pants every time. I found those really, really comfortable initially for the first 3 or 4 days before I just went to my own normal big comfy black cotton pants. Don't ever buy the disposable knickers. They're awful. They don't stretch. They're uncomfortable. They don't fit well. Just buy cheap cotton, big, nice, comfortable pants. But yeah, those, I can really recommend those sort of incontinence tenor pants. They were really useful. So that comfort for me on my perineum was one of the big things that was like happening to me in that period, because walking was difficult and going to the toilet was difficult. Actually, opening my bowels was really fine. I drank loads of water and I took Senna to make sure that I didn't get constipated. Not lots, just every sort of 2 or 3 days when I went to bed, I took a Senna dose. So going to the toilet was fine. The first time I was a bit nervous, but once that first time had happened, like it was fine after that. It was going for a wee because I had some stitches on my labia that was really sore. So I would wet a flannel and hold that to the area that was sore on my labia, so that weeing was really comfortable, and it just made all of that just a little bit easier to do that, because for me, the thing that was making me feel tearful and a bit down and a bit low was how sore I was. So anything that made that less sore made me feel better in myself. I said before, the nighttime snacks can be really, really nice. I love chocolate. So I had an awful lot of chocolate in those first couple of weeks, but I needed it. And I got some really nice, like fizzy elderflower drinks as well that were kept cold in the fridge, and I'd get one of those out and drink that in the middle of the night. And those little things were really nice in the middle of the night when I was tired. And then somebody bringing me a cup of tea first thing in the morning with a couple of pieces of toast and plonking them in front of me at like 6, 7 o'clock in the morning was the best thing ever. That really, really just helped start my day well, because I didn't even have to think about it. So somebody just plonking food and drink in front of you because you're just not thinking about it, because you're devoted to this little being in your arms, was really, really amazing. I felt the responsibility of keeping her alive really, really strongly. I was a bit overwhelmed by actually how scary it was, and I was surprised I felt that way, because I hold babies all of the time, but because she was mine and because I was now responsible, it made me realise what it's like when the midwife leaves. So when the midwife comes and does her visit and tells you that everything's fine and you're full of confidence and you think, yeah, we're good, we're all right, and then she leaves and you're just like, she's not coming back for a day or 2 days, and all of a sudden I felt that, oh no, now I've got nobody to ask, or I've got that weight of responsibility of keeping her alive in between that time, and suddenly am I doing it all okay again? It's just remembering to use your contact numbers if you need to ask again, it's fine. Like, talk with your support network, like to voice it, just say how you're feeling, say what you're thinking. It's really important to share that and not hold it in on yourself, because once I would say, oh, this feels a bit, it would then pass, and then I felt much better again. But I was surprised at how much responsibility I felt, given that I do have experience of holding those and looking after those wee little babies. So I chose to breastfeed, and again, I've got a lot of information and experience, and yet that was also one of the most challenging parts of my journey as well. I was very lucky that I got a really good milk supply quite quickly, so I didn't have any problems with milk. I had more than enough for her. She didn't particularly lose very much weight, and then she went on to gain weight quite soon afterwards, so her weighings were all fine. But for some reason, between her and me and her mouth, or what it was, I don't know, she didn't have a tongue tie. But when we would feed, her latch was very, very sore. No trauma on my nipple, no damage, no cuts, no bleeding, nothing sore. It all looked fine. I used nipple cream right from the beginning to try to protect them as much as possible. I had organic bamboo breast pads to try and stop any like material sticking to the skin. So I did all those things to help that skin be really healthy. But for me, her latch was actually quite sore. But everybody that assessed us said it's a really good latch, and the milk supply was fine, and she was really healthy. So it was like so I didn't really have anything to change. Although we did like practice with different positions and try alternative ways to latch her and where her body was, and laid back feeding and lying on my side with her. So I tried lots of different positioning, but the latch was sore. And I think one of the biggest things I've learned is sometimes the breastfeeding is going really, really well, but it's uncomfortable because my breast, my nipple, that skin is getting used to that for whatever reason, but there's nothing actually wrong, and it takes time. And I think because I didn't get mastitis, I didn't get any thrush, like my baby was healthy, I felt like I could persevere, and I just took it one feed at a time, and I just kept thinking, hopefully this will pass. And just as I was beginning to think, I don't know if I can do this anymore, all of a sudden that pain just went, and all of a sudden feeding was really easy and really comfortable, and that took 8 weeks. When it comes to newborn babies, there's an awful lot of advice and information out there, particularly at this time now when we can go online and find so much information about so many different experiences and perceptions and attitudes. And it's surprising what we might have our own bias and judgments on. So I was struggling at about 2 weeks with how to comfort and settle my daughter, particularly in the evenings. I couldn't always settle her with the breast because we were finding the latch quite painful, so I just needed to do that for feed rather than also for settling at that time. And for me, using a dummy really helped us through that period of time and has been a way for me to help settle her and comfort her without it. And sometimes I do use the breast now, but without it always needing to be the breast, and has soothed and reduced both of our stress. But when I first bought and used that dummy, I actually found myself sitting in floods of tears when my mum walked in, having taken the dog for a walk, and I'd given her this dummy while my mum had been out, sitting there crying, holding my now settled sleeping daughter, but finding myself in tears because I felt so guilty for having given her this dummy. And it is surprising where your own self-judgments and your guilt comes from, and I don't think we can necessarily prevent those happening, but what's really important is that you choose the things that are right for you, no matter what anybody else thinks of them. We are all making choices for our children that are in their best interests, and hopefully in line with our own instincts of what's right for them, because we know them better than anybody. The dummy has worked really well for us, and it has still been hard for me to use it out in public because of this self-judgment that I have imposed on myself. But that's got easier and easier and easier because I've learned to trust my own instincts, and it's been the right thing for us. So when people say to me, being a midwife and now having had a baby, would you do anything differently when you go back to work? None of my practice is going to change because it is as I thought it would be. But I really get it now, and I have a deeper understanding of what it's really like. And one of the things is definitely the postnatal period, with which I would talk with women more about. Sometimes the challenges, depending on what they are of that time, can take a little bit longer to recover from than actually maybe we've anticipated. So where I might thought that after 2 weeks I was going to be fine, in terms of my perineal recovery and feeding being comfortable, it actually took more like 6 to 8 weeks for me to pass through that phase. So that came as a bit of a shock, and I wasn't quite prepared to give myself as much time as I needed to give myself. So that's all I would say to women now, is be prepared to perhaps have to give yourself a bit longer than you anticipated, and just surrender to that if you can. It was my first baby. I could do that perhaps a bit more than you can when you've got older siblings, but as much as you can, develop that support network around you in the ways in which you're able to surrender more to whatever your recovery is like with that baby, because it might not be over as quickly as you want it to be, and that's okay, and it's normal, and it all gets better and it all passes, and that's okay. Thank you for watching this section on what to expect from the care you'll receive in the period of time after giving birth. I hope I've been able to reassure you that the postnatal period comes with many positive experiences alongside some individual challenges that will all be unique to each and every one of you, but that we will be there as midwives and health professionals to care for you and advise you and support you during that time. Any of the resources that I've mentioned throughout these videos, and a few extra ones as well, are all available in the PDF document, so please don't forget to check in with that and look at all of the resources available to you. I hope that you enjoy all of the other upcoming videos. Please do watch those. I've not talked about infant feeding, sleep and physiotherapy, pelvic floor recovery in great depth, because those other experts are coming to give you all that information on that for you. Please don't forget to drop in and join us on the private Facebook community with all those women who are either currently or very recently going through this postnatal period with you. Feel free to drop in there and ask us any questions, or come and see what women are talking about, share and support along with us. Thank you very much, and I wish you all the best with you and your newborn baby. Hi, I'm Natalie, and these are my 5 top tips for the early days and weeks with your newborn baby. Tip 1, if you are watching this before you have given birth, is to make a postpartum plan. It's really important before your baby arrives to prepare for this moment. It can be really easy to only focus on the birth and then feel a little unprepared for what comes next. If you're watching this pack before your baby has been born, you are already making your plan, which is amazing, great. So my top tip for this plan is your support network. Think about who is available to you to support you during this time, whether it be taking older children out, doing a school run, providing you with meals, how much cooking and freezing can you do, perhaps during your maternity leave period, of filling your house and your kitchen with food. Snack bag for overnight treats, you name it. What can you have in for supporting eating and drinking, your people that are around you to support your ability to rest, recover and have food plonked in front of you. Tip 2, regardless of how your baby has been born and how well you might feel, first week is stay in bed week, second week is stay on the sofa week. Please take the time to rest and recover. Tip 3, use your numbers, whether that be the health professionals or your support network. Please don't be afraid to ask for help if there is a challenge that has come along that you were not able to plan for or have foreseen, that means that you need additional support and help, whether that's physical or emotional. Please don't be afraid to ask for help. Tip 4, tenor pants. For the first 1, 2, 3, 4 days following birth, where your blood loss is at its highest and can sometimes come in some gushes, and to stop all those leaking and to feel comfortable with comfortable pants on, whether you've had a vaginal birth or a cesarean section, tenor incontinence pants, comfortable, soft. Use sanitary towels within them as well, so you don't have to change them too often. Top tip. Tip 5, if you've chosen to breastfeed, I can't highly advocate enough that you start nipple care right from the beginning of your journey. They won't be sore yet, they'll feel absolutely fine, but start your nipple care right from the beginning, because they will undoubtedly have to go through a transition of hardening up to breastfeeding, and there will be soreness that is attached to that, with the best of latches and the easiest of breastfeeding journeys. So think about your nipple care before you have your baby. if you're watching this pack before your birth has come along, but wherever you are in your journey, start your nipple care now.